Firstly, because prognostic, it has no prognostic importance, because and second thing is that since the patient is having hypertension, most of us are afraid of doing angiography in that case. So this angiography is the only tool by which we can diagnose this.
So you're right. I mean, I must say, in patients with malignant hypertension, if we see something like that and the blood pressure is high, we're not going to, in like the first case, we're not going to do an angiogram, we're going to treat the hypertension. And maybe we're missing it, and and we're not being careful enough. I think it's so non-invasive to do an OCT that maybe if we OCT them, we could, and did an angio-OCT, we'd pick more of these out.
So I have a question in terms of, do you anticipate most of these changes in the first, second and third branching of the arterioles? Because the one which are temporal to the fovea, you have the pinpoint hyperfluorescence can happen because of choroidal necrosis, the focal necrosis which can happen because of the choroidal circulation. Most of these FIPTs do happen in the first, second and third. That has been my observation.
So, it's the distortion. So you're saying it happens in the third order?
The observation has, yeah. You got it?
Yes. So why does it happen in the first and second, or
most of these observations, what I've seen, changes do happen in the first, second, and third branching of the arteriole. They don't tend to happen beyond it.
Yes.
Not sure.
Not sure.
But can I ask, what is the significance of FIPTs other than its specificity, as you mentioned, to malignant hypertension? Is there a correlation with other systemic problems in the kidneys and the brain?
Yes, this is very important because this FIPTs is caused by the focal dilatation of the terminal arterioles, precapillary terminal arterioles, and the cotton bowl spots are caused by the occlusion of the terminal arterioles. So, I have read somewhere while studying this thing that this the presence of FIPTs, it was earlier thought that it is a precursor of cotton bowl spot, which Dr. Sohan Singh Here told us, no, it's not precursor, it is entirely a different entity. So, it is because of the dilatation and breakage of the interendothelial cell junction. So, that is suggestive of hemorrhagic stroke. But it is an alarm that this type of hemorrhagic phenomenon can happen. Whereas the cotton bowl spots are occlusion phenomenon. So, that can lead to thromboembolic phenomenon and many other things.
Yes. Dr. Dogra.
I think they are not rare. He already mentioned, we have seen a lot of them in renal retinopathy patients. Also in some occlusions, where the vessel becomes thrombosed. It is absolutely dark. You must have seen sometimes the occlusion, vascular occlusion is different. Where the vessel is totally dark, we find these FIPT. In fact, we have demonstrated that. So it's not that they have been sort of reported. So it's not that specific. So we have seen them in those cases where you have like almost thrombosed vessels, very dark vessels. You may have such findings and they will leak the same way. And many a time, because in renal retinopathy patients, we are not doing angiography, so we may not be demonstrating, but we have demonstrated in some of those cases also.
But what is the cause of this pinpoint hyperfluorescence in this patient? It is all
I think maybe something to do the way probably initially, because of whatever the back pressure or something, why it happens specifically in thrombosed vessels, which we have seen. There also probably is some kind of stasis or something happening which is leading to this.
Dr. Here says that it is one of the earliest lesions to appear in a malignant hypertension.
Yeah, maybe they were noted first in malignant hypertension, but are seen in other conditions.
Right. So thank you, Doctor.
Thanks a lot.